Hello, welcome to our 10th Asian Pediatric Pulmonology Society Grand Round. We are very proud to present another interesting case with you today. And as the president of the APPS, my name is Arunwan Pritipan. I would like to thank Sri Lanka College of Pediatricians and also Childhood Respiratory Disease Study Circle of Sri Lanka to co-host this event. Childhood Respiratory Disease Study Circle of Sri Lanka is the official respiratory chapter of the Sri Lanka College of Pediatricians. And the case coming from Sri Lanka, and we are lucky to have the moderator, Dr. Shana De Silva. He is the consultant pediatric pulmonologist, Lady Ridgeway Hospital for Children, Colombo, Sri Lanka. It is our honor to say that he is the first pediatric respiratory specialist in Sri Lanka. So please welcome Dr. Chana De Silva.
Thank you. Very warm welcome to you all. Good evening to all. So this is welcome to the 10th APPS Grand Round. First, I would like to thanks Professor Arun Prathapan, the president of the APPS. Actually, first to invite to us to join this prestigious APPS Grand Round. So we are just developing our services in Sri Lanka. Just 7 years ago, we have started specialized pediatric pulmonology service in Sri Lanka. So this is one of the landmark in our history of development of pediatric pulmonology. So we would like to happy to discuss a case managed in the Colombo, Sri Lanka, a premature baby before the COVID period, born prematurely, but showed some features of atypical features of BPD, pointing towards possible interstitial lung disease. So we would have three eminent panelists for the discussions today. First, I would like to introduce Professor Mahesh Babu Ramamurthy. He is the senior consultant and the head of the Department of Pulmonology and Sleep Divisions, Department of Pediatrics, National University Hospital, Singapore. I am sure that he is not very familiar to you. He has participated as a moderator for the, and the resource person previous time rounds as well. And today we have Dr. Daniel Gmit, Honorary Consultant, Department of Pediatrics, Hong Kong Sanatorium and Hospital, Hong Kong, China, the founder president of APPS. It's a privilege to have him also as one of the panelists. And first time in APP's Grand Round, we have radiologists also. There are many X-rays and CTs to be discussed today. So we have the privilege to have Professor Manisa Jana. She is a professor, Department of Pediatrics, Department of Radio Diagnostic and Interventional Radiology, All India Institute of Medical Sciences, New Delhi, India. So with these panelists, there would be a very fruitful discussions. And I would like to introduce my colleague, Dr. Anuradha Kodipili, consultant pediatric pulmonologist working Lady Hospital for Children, Colombo, Sri Lanka, and senior lecturer in Department of Pediatrics, University of Colombo, and she is the current secretary of the Sri Lanka College of Pediatricians. So Anuradha will present the case and she will go through the rest of the presentations. Over to Anuradha.
Thank you very much, Channa. Hope you all can hear me. So very good evening to you all. And then let me thank you very much for that kind introduction, Channa. And let me thank the APPS and the Sri Lanka College of Pediatricians for supporting this grand round. So today we are going to discuss this case as Channa introduced. So our theme today is respiratory distress in a preterm infant, respiratory distress syndrome or child. Next slide, please. So let me start the case with a referral. Next, please. Next. Yeah. So our patient is a 1-month-old girl who was referred to tertiary care hospital in Sri Lanka, Colombo, Lady Ridgeway Hospital, from a local hospital which is about 100 kilometers away from Colombo for pediatric pulmonology opinion. So why have they referred this baby to us? Due to persistent oxygen dependency with respiratory distress. Next slide. Next. Yes. So let's move on to the perinatal history. So this is the firstborn lovely baby to non-consanguineous healthy parents. And then it was a planned pregnancy. There had been no antenatal complications. And then child was delivered due to premature rupture of membrane at 29 weeks of gestation. And then the mother has received 2 doses of antenatal steroids prior to the delivery. Next. So birth details, it was a spontaneous vaginal delivery at 29 weeks, as I mentioned earlier. And then the birth weight was not bad. It was 1.305 kilograms. A baby was delivered at local hospital, and the delivery was attended by the medical officer and the nursing and the midwifery staff of the local hospital. Next. So let's see the respiratory status at birth. Child's APGAR had been 6, 8, and 10. They have not been bad. And the child had cried at birth. And then, so they have provided routine delivery room care. So despite being a preterm baby, at birth, there had not been any resuscitation at the delivery room. And then the vitals, initial vitals has been stable with a pulse rate of, respiratory rate of 56 per minute, which is normal at birth. And pulse rate had been 146 with a saturation of acceptable saturation of 90%. And then the baby was observed post-delivery due to the prematurity. Next. So let's move on to the story. So then so baby did not behave as stable afterwards. So at 4 hours of age, child was noted to have some respiratory distress, basically the tachypnea. There was worsening tachypnea, respiratory rate was over 60 per minute. However, if you see this, you can see that the Silverman score had been 4. It had not been very severe. So mild intercostal and subcostal recessions were recorded, and then the saturation, room air saturation, had been 86%. So, however, the MO, medical officer who attended the delivery, was a bit worried about the distress. Obviously, it's a 29-weeker, so he proceeded with intubation. And then the child was intubated and started on SIMV with a PEEP of 16 and a PEEP of 5 centimeters. And then the child required not very high, but about 25 to 30% oxygen. Next slide. So look at the chest X-ray on day 1. So I would not explain the chest X-ray in details because we have an expert who will be going through the chest X-rays, but I hope you would appreciate that the volume of the chest X-ray, the volumes of the lungs are decent, and there had been no significant ground glass opacity. However, you can see some reticular shadows in this chest X-ray, which will be explained by us, the speaker later. Right, next. So, so what happened after that? So this is weaning of respiratory support by day 1. Even though the child was intubated after 4 hours, in 4 hours of birth, they could gradually wean the respiratory, the PIP that they have started 16, they gradually wean that, and then they could extubate the baby by 10 hours of birth. So there had not been significant pressure requirement. By 10 hours of birth, they could extubate the child onto CPAP 6 centimeters. So on CPAP, baby's oxygen requirement 35%, again, not very high. And then what did they do after that? So they proceeded with weaning further, and then CPAP was transitioned to nasal cannula oxygen by 22 hours. So from 10 hours to 22 hours, roughly around 12 hours, child had been stable on CPAP with no deterioration and with no observable significant respiratory distress, which led the team to wean the child onto nasal brown oxygen. So we will have to analyze this and see whether that was the right step to be done at that point. Then let's see how the child behaved. The baby behaved on nasal brown oxygen. Again, there had been no significant respiratory distress, but the tachypnea persisted. So the recorded oxygen requirement was 0.1 to 0.2 liters per minute. That was the nasal cannula flow, which comes to 60% when we calculate the FiO2 requirement. So they have targeted lower 90 saturation on these settings. Next. So what was the oxygen requirement at day 1 of life? Don't worry too much about this formula. Basically, this is the formula which is used to calculate the FiO2 requirement based on the nasal cannula flow that you provide. So this baby was 1.3 kilos, respiratory rate was 60 per minute, and then the oxygen flow was 0.2 liters per minute. And then the first equation shows the minute ventilation, and then minute ventilation had been 429 milliliters per minute. And then when you calculate, the FiO2 comes to about 58 to 60%, right? So the FiO2 requirement, hope you would appreciate, even though the child was on 0.1 to 0.2, the FiO2 requirement had been pretty high. And then the ratio of SpO2 to FiO2 was 163. Next slide. So how did this child progress? So the progression on nasal cannula oxygen up to 1 month of age. So tachypnea persisted. So the NICU was given meticulous care to this baby, but the tachypnea persisted, but there had been no significant respiratory distress throughout, no hiccups. And then, however, they faced inability to wean oxygen. So saturation in room air always remained less than 90%, around 85 to 90%, leading the NICU team to continue nasal cannula oxygen 0.1 to 0.2 liters per minute. Right? And then other medical concerns, so around day 6 of age, baby developed slight fever spikes with some lethargy. So because it's a preterm baby and who had premature rupture of membrane, they treated for presumed sepsis and started the baby on IV antibiotics. Next. So oxygen requirement, so I don't want to brainstorm with another calculation, but it's the same calculation that we used. And then by 28 days of life, you can appreciate child had gained some weight had been 1.54 kilograms, respiratory rate 56%, slightly lower than the initial rate, and the oxygen flow rate requirement to maintain a lower 90 saturation had become decreased to 0.1 liters per minute, making the FiO2 requirement 37%. Now you can see that this SpO2 to FiO2 ratio had gone up to 264. Next. Yeah, look at the subsequent chest x-rays. So day 5 and day 15, when this baby was unable to be weaned from oxygen, they have taken a couple of more x-rays. And then you can see again slightly rotated x-rays, but no major consolidation or no major collapses. Volume, of course, these x-rays are hyperinflated, but Manisha will explain them further. And I think you can, even a person with a little bit of radiology knowledge would appreciate that there is some reticular shadows on bilateral diffuse reticular shadows. Next. Again, 2 subsequent x-rays, day 25, day 36, more or less the same, hyperinflation, more marked reticular shadowing, but no major consolidation or collapses or significant ground glass opacities. Next. Okay, so because the child was slightly septic, so they have done all the basic investigations, septic screening, and so I don't want to go through each and every investigations, but all the investigations, hemoglobin, white cell count, C-reactive protein, you can appreciate that it had never been high. So the thing that we need to understand is there had been no significant infection explaining the oxygen dependency throughout because all the investigations had been normal, and even the blood cultures also repeatedly showed no growth, and then the electrolytes had been normal. Next. So they have done other basic evaluation as well, because this is a premature child. Serum calcium, magnesium, blood urea, creatinine, renal functions had been normal. Thyroid TSH was done, which is normal, and then the blood group of the baby was O positive and mother's blood group was A positive. An ultrasound brain, obviously when the child is oxygen dependent, plus a premature, we would do an ultrasound brain, the ultrasound brain. There was mild choroid plexus hemorrhage, but repeat ultrasound brain had been normal with no progression. Next. So other evaluation, again, premature baby, difficult to wean oxygen. They did echocardiogram to see whether there's any structural anomaly of the heart, or to see whether there's any evidence of pulmonary hypertension, but there had been, so that had been normal with no evidence of pulmonary hypertension. Next. So at this point, the NICU team felt this child has got no other explanation for oxygen dependency other than the prematurity. However, the chest x-rays are not the typical of bronchopulmonary dysplasia. So they decided to refer this baby to tertiary care pediatric pulmonologist for opinion. So the baby was referred mainly due to oxygen requirement, and the radiological findings raised the suspicion of childhood interstitial lung disease. Next. So the child was referred to pediatric pulmonology team, and then baby was referred as an outpatient referral. So this was the evaluation by the pediatric pulmonology team. So they appreciated that child is a very low birth weight baby born prematurely at 29 weeks. And by the time the baby was referred to the pulmonology team, the gestational age at referral was 33 weeks. Still, we are not surprised that the child is asking for a bit of oxygen. So that is not the only reason for referral. As I mentioned, was poisoned. Practice until the baby is ready to take the breast. On examination, the pulmonology team has not appreciated any dysmorphism. Baby was handling well, pink baby. No, I want to highlight that there had been no significant intercostal or subcostal recessions. Can you all hear me? All right, okay. However, the striking thing that they have observed is that the child is tachypneic with a rate of 60 per minute with few inspiratory crackles. Next. So this made the pulmonologist to evaluate for the reasons of oxygen dependency at this point, clinical evaluation, just to narrow down the most likely reason for the oxygen dependency. So obviously, the chest X-ray, as I have shown earlier, you all have appreciated that there are some abnormalities in the lung parenchyma. So is it BPD? Is it child? However, they just run through the other systems clinically just to see the possibilities. Airway, there had been no stridor to suggest upper airway obstruction. There's no significant recessions that you typically see in children with airway malacia. And then there's no pressure dependency. Child was weaned off pressure very quickly. So clinically significant airway malacia is unlikely. And then central, so the PBU team, the NICU team has never recorded apnea, never recorded intermittent desaturations. Oxygen requirement was static. So central apnea is clinically unlikely. And then there's no ongoing chest infection. You have seen that the x-rays are not suggestive of any consolidation or congenital pneumonia, and the inflammatory markers were not suggestive. So chest infections were anyway was felt to be very unlikely. And secretions, no significant secretions. Cardiac, they have already excluded. Baby had a very good tone. X-rays showed normal diaphragm, no diaphragmatic eventration. And then aspiration, feeding had been successful. Child had gained weight. No cough with feeding, no vomiting or regurgitation. So clinically significant reflux and aspiration were felt to be unlikely. So after evaluating all these things, the pediatric pulmonologist felt this is lung parenchyma. Is it BPD or child? Next. So he requested the CT. Next slide. So next slide will give some closer view. Next, please. Yeah, so you can see again, I'm not going to go into the details of these CT images which will be described later, but hope you can see that there is some air trapping, and obviously you can see the lobular structures and you can see some septal thickening in these chest x-rays, which is not the typical CT that you would see in bronchopulmonary dysplasia or respiratory distress syndrome. Next. What did the pediatric pulmonologist advise at 6 weeks of age with their first encounter? So his impression was that child is more likely with the overall clinical picture. So can we offer anything at this age? No, we can't offer anything specifically. We do not have genetic ILD panel in Sri Lanka that you can do to diagnose. But we gave supportive care. So we continued nasal cannula oxygen and aiming a saturation of just about 92%. And then advised to establish the feeding and optimize nutrition, because nutrition is very, very important for lung health. And then recommended special vaccinations, non-EPI vaccinations, because pneumococcal is not included in the government EPI schedule in Sri Lanka. But if it is a child who has a vulnerability to get severe infections, we do recommend special vaccines. So the pulmonology team recommended special vaccines. And then we recommended overnight oximetry and saturation monitoring at NICU to see the progression, and then monitor for the oxygen requirement. And then we advise to prepare the child for long-term oxygen therapy, and then to follow up for pulmonary hypertension. Next. So what did the NICU team did? So they did a marvelous job. They continued nasal cannula oxygen. They successfully established feeding, cup feeding, then subsequently breastfeeding. Vitamins and mineral supplementation were given, and then the child was monitored closely for the clinical progression. Obviously, because it's a 29-weeker, they did ROP screening, and then initially was under ophthalmology follow-up. Next. With the advice of pulmonologists, because we did not have a clear clinical picture, it was between child and respiratory distress syndrome, hoping to treat respiratory distress syndrome because the child is a premature child. We asked them to do a trial of DART protocol. That was given, but there was no clinical response and the oxygen requirement remained static. Next. So what else did they do on the NICU? So response to steroid, as I have mentioned, was there was no response. But we started inhaler beclomethasone initially 100 microgram twice daily. We do not have 50 micrograms MDIs these days. And then home oxygen, nasal prong oxygen continued 0.1 liters per minute. And then saturation monitored primarily with continuous pulse oximetry. And then they arranged for home oxygen. And then the logistics issues, it took some time, and then the baby got stuck on NICU for 3 months to get everything arranged and then to send the baby home. So during the 3 months of NICU stay, baby continued nutrition support was given, and then at 3 months of age, baby was discharged with a weight of 2.6. Next. So this is the initial, with the age, initial SpO2 FiO2 ratio. You can see that it started slightly rising up. Next. Okay, I would stop at this point and hand this over for the poll question. Thank you. So the poll question, what is the likely diagnosis? So we have 5 answers. I hope the audience can, at this stage, after listening to the clinical picture, having seen the radiology, and then the progression to progression with oxygen requirement, plus the response to DART protocol, I hope you can choose one answer out of these 5. Yes, we can see the results. 29% telling respiratory distress syndrome due to BPD, 20% telling it's a factor protein deficiency, and 18% of the audience felt it is pulmonary interstitial glycogenosis, and then 31% says it could be either RDS or pulmonary interstitial glycogenosis. Lovely. And then 2% thinks it's Wilson-Milky syndrome. Prof. Manisha.
Good evening. Thank you. Thank you for this wonderful case description. Now I'll be discussing about the imaging. Although briefly it has already been discussed by Dr. Anuradha, but I'll just go into a little bit of detail. So next. So this was the first radiograph that we saw. So what to be noted is that the first thing that strikes us that for a premature child, the lung volumes are pretty good. Actually, they're bigger. The lung volume is more. It is not small volume lung, so that kind of keeps the possibility of RDS much lower down, because in RDS what we see is usually typically small volume white out lung. That is not the picture over here. Here it is either normal or increased lung volume, and all through the lung there is streaky opacities. Streaky densities can be seen all throughout the lung volume everywhere. And the UVC line is way too high up here. Next. This was the day 1 radiograph. So on this radiograph, what would have been our possibilities? So why would I not keep RDS as the first possibility? Because of the lung volume. And first thing is the lung volume, which is bigger here. And this streaky lung opacity. It is not a ground glass opacification or white out lung. I'd rather keep childhood ILD, like pulmonary interstitial glycogenosis, as a possibility because of the first thing that it presented very early and there was increased lung volume with uniform smooth septal thickening. And why this is not viral bronchiolitis? Because it presented way too soon and it is very uniform. And similarly for sepsis, the picture was too diffuse, symmetrical, and uniform. So these were the main diagnosis or radiological possibility that we could keep on the chest radiograph of day 1. Next. Now let's see how the disease progressed on radiograph over 1 month. So first one is day 5 radiograph, followed by day 15 radiograph, followed by day 35 radiograph. So in all the radiograph, the first thing that strikes our eyes is hyperinflation. So many ribs are visible. Anteriorly, more than 6 or 7 ribs are visible. So that makes it a hyperinflated lungs. And these reticulations or streaky opacities, they are uniform and they are persistent throughout till 1 month or 35 days. So this picture is again it is in keeping with pulmonary interstitial glycogenosis, one form of infantile ILD. Next. Now, a CT chest was done at 6 weeks of age. And again, what we see is that those reticulations that we saw on the chest radiograph, they are actually not the fibrotic areas, because we can see that those smooth septal thickenings, they were taking the shape of the secondary pulmonary lobules. So like even at the periphery also, if we see, they are becoming polygonal. It's more like secondary pulmonary lobule is being demarcated by septal thickening. So this is smooth interlobular septal thickening. And within the lobule, there is increased lucency, which indicates that there is air trapping as well. So there was a superimposed 2 findings. One is air trapping, and there was smooth interstitial septal thickening, which is diffuse and uniform. Next. So what we can think on the basis of this combination of these 2 imaging findings, hyperinflation plus diffuse smooth septal thickening. So here, as you see, that the possibility of a childhood ILD, I have brought it up because of the first thing that it does not show the typical progression of BPD in RDS, and the appearance of RDS on the first radiograph, it was not suggestive of RDS at all. And preserved or increased lung volume and diffuse smooth septal thickening. These 2 things and the CT appearance, they go more in favor of a childhood ILD, that is PIG. Then RDS followed by BPD, I explained why this is not the first possibility that I would give. Another childhood ILD or NIHI, neuroendocrine cell hyperplasia of infancy. This is mainly it shows ground glass opacity and hyperinflation, but septal thickening is never a predominant feature of NIHI. So that is why we would not keep this as in the top of our diagnosis. Then surfactant protein abnormalities like SPC or ABCA3 mutation, the presentation was way too early and there was no ground glass opacity on CT at all. And childhood ILD remains the first possibility, especially PIG. Next. So on the basis of these 2 imagings and the serial evaluation of the radiographs, we would like to keep childhood ILD, most likely pulmonary interstitial glycogenosis, as a possibility. Next.
Thank you, Dr. Manisha. I hope I'm audible. I'm Dr. Mahesh here. Okay, so in summary, what have we heard? I'm Dr. Mahesh, and basically the question to me, I'm carrying on the question from the poll that we all stopped. and the audience is very clearly equally split between all the three options. A third of you said RDS, a third of you said chILD, PIG, a third of you said it could be a combination of two. So basically, there is a lot of split in the audience. So let's kind of analyze, and I'm sure all of us have difficulty in pushing one over the other, only because this entity called RDS, which we will discuss, is very common. This entity called chILD, which means childhood interstitial lung disease, is very not so common. Let me put it that way. It's not so common. And the second thing is, each center on its own will not have enough cases to discuss and see all types of chILD. And therefore, even in the West, they always have multicentric approach to getting cases and registry and applying them. So that's the problem with diagnosing these with certainty. Let's see what. So far we have had a term baby who's 29 weeks gestation, received antenatal steroids and oxygen since birth, was dependent, required intubation within the first few hours of birth, but was weanable quickly to CPAP and to nasal cannula by 10 to 12 hours, remained on zero point 0.1 to zero point 0.2 liters by nasal cannula almost till 5 months, till where we have received the story so far. The oxygen requirement continued till 5 months of age. The baby was thriving reasonably well from what the organizing team is telling us. No other respiratory infections were there in this child at that time. So, differential diagnosis to me at this point of time, I know we had a big list, but after looking through the whole summary, I would say it's either an RDS with or without BPD, or it can be a childhood interstitial lung disease, or it could be a cardiac pathology. We were told very clearly the child had an echo and cardiac pathology was ruled out. So the differential is between 1 and 2 at this point of time. So let's look at what RDS is. It's something that all of us have read and known. Respiratory distress syndrome, also called as the hyaline membrane disease, is because of surfactant deficiency. Surfactant is produced by the type 2 alveolar cells, and these cells mature as the gestation of the baby goes up. And therefore, if the baby is premature, then it's very likely that we are going to have more and more incidents of surfactant deficiency. What is surfactant useful for? Surfactant is useful for keeping your alveoli open by reducing surface tension. So if you do not have good quality surfactant or no surfactant at all, then the alveoli are going to collapse, causing atelectasis. When you have multiple atelectasis everywhere in the lung, the X-ray shows a whiteout lung. Because it is atelectasis of the lung volume shrinks, and that is why Dr. Manisha was telling you in a typical RDS, the volume of the thorax decreases. As I was telling you, the incidence of respiratory distress syndrome increases with decreasing gestational age. So if you look at 24 weeks gestation, 98% of those children develop RDS, whereas at 34 weeks, it will come down to just 5%. Our kid is around 29 plus 4, and the incidence is about 8% of RDS at that age group. Many centers in the world would have probably given surfactant to this kind of a baby, because this baby was preterm, developed respiratory distress very quickly after birth, in fact got intubated within the first 4 hours, and therefore just to make sure that we have treated the baby properly, if we have access to surfactant, a lot of centers would have given surfactant to this baby at this stage. In fact, if you look at European consensus guidelines, surfactant can be given to premature babies if the FiO2 is more than 30% within the first 24 hours. So by that criteria as well, if you have access to surfactant, we can certainly give surfactant to this baby. Chest radiology has been discussed. Usually radiology in a child with RDS will show bilateral diffuse opacity. If the RDS is mild and if there are no other problems, RDS will settle down with time if there is no development of BPD, and the oxygen requirement should come down. What happened to our kid? In our kid, the oxygen continued to be there, and therefore the child continued to require oxygen, and therefore something else was happening in this kid. And the commonest progression of respiratory distress syndrome is to bronchopulmonary dysplasia, which we all call it as BPD. This BPD is a fine loss of balance between lung injury and lung repair. So the child's lung is trying to repair, but the injury, because of the surfactant deficiency and later on because of invasion by our interventions, will cause more lung injury and it causes significant BPD. The definition of BPD has undergone significant changes, and you will see that in this slide. I'm not going to bore you with the whole slide, but let's to tell you, any child who requires oxygen at 28 days of at 28 days postnatally or at 36 weeks of gestation is likely to have a BPD. This was the initial classification, but now we have got more and more very clear classifications, and I want you to concentrate on the 2019 classification, which says if a child has got less than 2 liters per minute of oxygen at 28 days after birth, this child is likely to have mild BPD. And that probably is what our child can be envisaged to have at this stage. If I was the treating person, I would still very early think it is an early BPD which is still developing. But you should know that most children with BPD, if they don't require very high ventilation, like in our kid, will improve with age, though it can be a little variable, and they do come off oxygen over a period of time. But that did not happen in our kid, and we have already heard that the radiology is not typical of either RDS or BPD in our child, though sometimes I think a BPD child can also have hyperinflated lungs, nodular looking lungs on an X-ray if the child is intubated or is on high CPAP, which our kid was not for a long-term basis. So this brings the possibility of another pathology like chILD. Now, childhood interstitial lung disease, the first thing I want you to tell you, this terminology is a misnomer. When you read the word childhood interstitial lung disease, all of us think that there is the interstitial problem between the alveoli and the blood vessel. No, it is not. In fact, childhood interstitial lung diseases can have involvement of airway, alveoli, interstitium, and the blood vessels all put together. And therefore, it's a very complex mechanism, which group of diseases. And this group of diseases is not something very old. It's only in the last 2 or 3 decades people have started recognizing more and more diseases as childhood interstitial lung. And you can see here, you don't have to go through every single detail. There are about 28 to 29 subgroups of what we call as chILD. So we can't have every child in whom we think of chILD. We do not need to go through all the 28 subtypes. So then how do we differentiate? We differentiate in this particular child, we have to look at what are the causes of chILD which can come within the first 24 hours of birth. And that's what I'm going to look at. Interstitial lung disease is suspected in a term baby who has persistent tachypnea which cannot be explained otherwise. In a preterm, you can use the same definition, but the uptake will be less because in preterms there can be other causes of respiratory distress as we have discussed before. Okay, so in our child, because we think chILD developed very early, there are 3 differentials to be kept in mind of childhood interstitial lung. One is what we call as disorders of development. That means the first one is alveolar acinar dysplasia, which means the alveolar growth and the acinar growth get curbed or arrested at various stages of development and they don't develop very well. Or it can be the second category, which is ACD with misaligned pulmonary veins. You all know when an alveoli is there, it has to be surrounded by pulmonary veins for the transfer of oxygen to happen. So if there is no alignment between the alveoli and the pulmonary veins, gas transfer certainly cannot happen. And therefore, you can imagine both of these categories, ACD and ACD-MPV, cause very, very severe respiratory distress at birth, and mortality is very high within the first few days. Our kid luckily did not fall into this category, so we can rule it out. Next, we come to surfactant protein mutations. Is it possible? There are 4 different types of surfactant proteins, A, B, C, and D, and it can also be UPCA3. The surfactant protein A and D are proteins which are involved in immunity, innate immunity, and they do not contribute to surfactant function. Therefore, they will not produce chILD. So the 2 things that we need to remember is surfactant protein C and surfactant protein B. But B again, if you have a problem with surfactant protein B, these are autosomal recessive diseases and they cause quite severe disease at birth. And therefore, our child is unlikely to have surfactant protein B. What about surfactant protein C? C has a very, very variable course. Some children present at newborn. Some children can present later on in life. In fact, the commonest presentation of surfactant protein C is children who develop bronchiolitis and don't resolve after bronchiolitis, and they continue to have oxygen. There are children who get diagnosed with surfactant protein C at 4 to 5 years of age. In fact, there is a family of 3 children who have been described to have surfactant protein C. So it can be very, very variable, and our child can still have surfactant protein C deficiency. UPCA3 produces severe disease, and again, I'm going to discount that in our kid. Now, there's another big group of what we call as dysmaturity, disorders of dysmaturity. Here, a lot of you would have heard terminologies like knee-high and pulmonary interstitial glycogenosis being talked about as if these are individual entities. Yes, they were thought to be individual entities before, but of late, we recognize that these are not individual entities, but these are all part of the same group of spectrum. If there is a dysmaturity in the airways, it develops neuroendocrine cell hyperplasia of infancy. If there is dysmaturity in the interstitium, you develop pulmonary interstitial glycogenosis. In fact, pulmonary hypoplasia is also supposed to be a part of the same spectrum of dysmaturity. Now, NEHI, as was told before, they have a very classical CT scan. I will show you the CT scan of an NEHI. This is how a CT will look. It will have classic ground glass appearance in the lingular lobe on the left side and the middle lobe on the right side. Very, very classic. Our child did not have it, and therefore we can safely say our kid is unlikely to be NEHI. What about PIG? Certainly, yes, they can present with neonatal distress. A CT shows diffuse ground glass appearance and cystic changes, but these are not by any stretch of imagination specific to PIG. Therefore, on radiology, it is impossible to 100% say if somebody has got a PIG or not. The diagnosis should be made for PIG on histopathology. This is the first one is the high field microscopy, which shows that the basement membranes or the interstitium are thickened. And the next one is the electron microscopy, which shows the cytoplasm to be vacuolated. And this vacuolation occurs because of glycogen deposition. There's a lot of glycogen deposition. The prognosis in PIG is variable, but most of the children do well and can come off oxygen. So in summary, what have I said so far? I've said our child started with features of RDS and mild BPD, but however, there were changes of the CT and the clinical changes which meant to us that something else was happening. And that's when we started thinking of chILD. Because it occurs within the first few weeks, we narrowed it down to a few types, and within that, we now think surfactant protein C or PIG are more likely to be in this child. This brings up the importance of doing genetic studies for diagnosis of chILD in the world. There are many, many panels which are available. I know not everybody can afford to get this chILD panel done. But if somebody is really keen on getting it, you can write to people in the West, and the labs will be more than happy to accept it and entertain you with a free specimen sometimes. I have had it done when I was in India, and I'm sure you can do it as well. Biopsy is another thing. For example, for PIG, you need biopsy, but biopsy is ridden with a lot of problems. Morbidity, and even the local pathologist might not know how to read a biopsy. So you'll get stuck doing the biopsy and reading a biopsy. And therefore, a lot of us in periphery don't do biopsy anymore. I think I'll stop myself there. Thank you very much.
Thank you very much, Prof. Manish and Prof. Mahesh, for that lovely evaluation. So let me quickly focus on the second part of this presentation, case presentation. Now you can appreciate that we have changed the theme into neonatal onset child in preterm infant. Next. So what happened to our baby? So we discharged, hope you remember that we discharged this little baby at 3 months of age with a weight of 2.6. So how was the subsequent months? Next. Did she remain well? Of course not. She got admitted again about 6 weeks after the discharge, around 4 months of age with a chest infection. So she presented with fever, cough, nasal congestion, and worsening respiratory distress. Parents reported increased oxygen requirement. And then on examination, there was a significant tachypnea, respiratory rate more than 64, and then with bilateral crackles. Saturation dropped to 78% in air, increasing the oxygen requirement to 0.5 liters per minute. And then the investigations show more of a viral picture with normal CRP. Next. So baby was managed as viral bronchopneumonia. Respiratory support was given, high flow humidified oxygen 2 liters per kg for 1 day. Just to support, still being a premature baby, and then supportive therapy, intravenous fluid was given, and then empirical IV co-amoxicillin was given, and then child was covered for influenza as well, and then other measures, anti-reflux were given as precautions. So the outcome after this admission was child just required 6 days hospitalization, and we were able to wean oxygen from 0.1 oxygen back to 0.1 liters per minute. That was the baseline oxygen of this baby. But then unfortunately on discharge, we did not have low flow meters to give 0.1 liters per oxygen at home. So we were compelled to discharge the baby on 1 to 2 liters per minute nasal prong oxygen, probably 1 liters per minute nasal cannula oxygen. Next. So poor girl had another admission around 5 months of age. That was 1 month after the admission. Presented again with fever, cough, and fast breathing. And on examination, there were signs of increased respiratory distress, not very worse like earlier. I mean, earlier chest X-ray, there were some shadows. Again, other than the long-standing chronic shadows, there were no major consolidation or collapses. Saturation remained upper 80s in air. Inflammatory markers were negative, similar to the previous admissions, and then child was managed in ward with supportive care. Next slide. I'm pretty sure you are interested to know how this child, actually the growth of this child during this period. So I have highlighted 3 areas of the growth chart. You can see that when the baby was born with a 1.3 weight, and then by 1 month of age, there was steady weight gain. And you can see the green square from 1 month to 3 months when the baby was fed at NICU with cup feeding, there was a steady weight gain. And then the child was discharged around 2.6. And then at home, what happened from 3 months to 4 months, there was slight faltering of the weight. And obviously from 4 months to 5 months with 2 back-to-back infections, there was significant faltering of weight, and then child ended up in red zone. Next. So how did we follow this baby from 5 months of age to 4 years? Now I'm giving a long duration. So follow-up, baby was followed up at local hospital clinic 1 to 2, so once in 2 months. And then baby was referred to tertiary pulmonology clinic like every 3 to 6 months. And then there was some interruption of care, lost to follow-up during over about 18 months during COVID period. However, parents reported that the child obviously remained well without a significant chest infection. Clinically, no hospital admissions, just mild upper respiratory tract infections needing general practitioner's treatment, and no significant wheezing episodes. Next. So oxygen therapy, what happened to the oxygen requirement? So parents continued 1 liter per minute home oxygen via nasal cannula. They basically use oxygen concentrator at home, and then they use low weight cylinders when the baby was mobilized up to 4 years. And then parents have made multiple attempts to wean oxygen plus the medical team. However, the off oxygen saturation remains suboptimal up to 4 years of age. And then parents reported persistent nocturnal desaturation. They did monitor oxygen with pulse oximetry. And then the baby was admitted to local hospital also to monitor overnight saturation. And then the saturation was suboptimal throughout. So off oxygen saturation initially dropped to lower 80s, but with time it improved to high 80s. And then subsequently, room air saturation was reported to be around 90, but still during night time, which is a normal scenario. You know that oxygen dependency is more during night. And then at night, the saturation dropped to upper 80s. Next. So we continue with inhaled beclomethasone just to support airway stability during periods of increased symptoms, cough and cold. But it was not a continuous usage of beclomethasone, just intermittent courses with long breaks. Feeding and growth and development, breastfeeding with formula top-up continued up to 6 months, and then the complementary feeding was started around 6 months successfully, and then the girl was transitioned to family diet by 1 year of age. And then the weight gain was appropriate, and then child followed normal growth centiles. And then milestones, there was a slight delay as we expect in a premature child, but then subsequently normal milestones were achieved. ROP, the baby was discharged from the eye clinic with the label of no ROP. Next slide. Okay, you can see the second zoomed picture, and you can see that the babies, initially it was on the red zone, less than -3 SD, but from 3 to about 4.5 years, there was a steady growth, and then the baby was in between on -3 SD to -2 SD. And interestingly, you can see around 4.5 years, child crossed the centiles up and reached the light green zone, which is more than -2 SD. Let's see what has happened around that time. Next. Yes, you can see previously we have shown the initial two SpO2 to FiO2 ratios in the first half. Now you can see the trend. You can see that gradually the ratio increased and then reached 450 by the age of 5 years. Next. Yeah, this is our lovely child. You can see next and next. Yes, you can see how the child grew. Lovely girl. We have shared these pictures with the consent of the parents, and then other than the nasal, wherein the nasal cannula looks like a normal baby. Next. Yeah, so a big step forward, baby became off oxygen around 4.5 years of age. Parents reported reduced oxygen use during the daytime. Child was able to be off oxygen for a brief period with a saturation of more than 94. So we did monitor overnight saturation like every 6 months, and then gradually, first we wean the daytime oxygen, and then subsequently we have weaned the nighttime oxygen as well. So child was successfully weaned off both day and night oxygen by 4.5 years of age. Next slide. So first year of off oxygen, there was a stable recovery. That is where the child was moving around, eating well, and then the growth improved, and home saturation monitoring continued, and then the parents did not report any desaturations, and then the repeat echocardiograms did not show any pulmonary hypertension, and then the child was growing lovely. Next. So what is the current status of this baby? This is a 6-minute walk test that we have done, and then interpretation was appropriate cardiorespiratory response with no significant desaturation or instability, and then the child's functional capacity preserved. You can see the baseline and the post-test parameters has been quite stable. Next. So this is a sleep study, overnight oximetry. I think Daniel will elaborate on this more, but you can see that the baby has a mean saturation of 99, and then the time, the dips per hour, more than 4% was even less than 1, and then child did not spend a lot of time less than 94%. Saturation spent less than 94% was actually 0. Next slide. You can see some dips. I think Daniel will elaborate on this. Next slide. Spirometry, of course, we attempted spirometry twice and at 4.5 years and around 5 years, but child just came off oxygen, and then child was not able to do a decent effort to do a good spirometry. Next. So how is this child currently? 6-year-old, nicely growing, height, weight, and the BMI, they are all on 25th centile. Child remains 97 to 99 saturation at rest, and there's no significant respiratory exacerbations. There was no store in pediatric sleep questionnaire was less than 0.33% at last evaluation. Child is regularly attending preschool, fully physically active, and there was no evidence of pulmonary hypertension. So next slide. So this is a very lovely case. So the child was actually weaned off oxygen, and then now we have a clinically normal child. So let's move with Manisha's explanation of the CTs.
Thank you. Next. So as we see the radiographs at 3 and 4 years of age, and we can see how beautifully the lungs have expanded. Now the residual septal thickenings are also barely appreciable. Actually, this can pretty well go as a normal radiograph for this age. So it's a very lovely thing that it has shown such good regression. So the lungs are well expanded. There is no fibrosis, no bronchiectasis, actually no signs of any residue to any interstitial lung disease. Next. So, these are the chest CT at 4 years of age, which showed some amount of hyperlucency, that is the air trapping, in the right middle lobe as well as lingula, which looked like hyperinflated. But of note is that there is no fibrosis and no septal thickening. And there is no ground glass opacification as well. So it's a very good CT to see almost near complete kind of resolution, barring this areas of hyperinflation in the middle lobe and lingula. Next. Okay, the poll question.
So thank you for the excellent presentation of my predecessors. I'm Daniel Ng from Hong Kong. I'm going to talk about the long-term management of chronic respiratory insufficiency, getting a better result. Next. So I'm going to borrow a slide from Dr. Anuvada. The key principle of management is supportive care, prompt treatment and infection, long-term specific management, and monitoring. Next. Supportive care, you may notice that the baby was fed by express breast milk by cup. So the reason why is that so is because of the sucking, swallowing, breathing coordination was not successful. Okay, and that's very common in preterm infants with respiratory distress. So it's important to engage the feeding assessment by the occupational therapist to rule out dysfunctional swallowing, which may lead to aspiration during the pharyngeal phase of swallowing. And that, of course, will cause chronic lung disease. And if we have the resources, we may need to do the video fluoroscopic examination swallowing is helpful. If there's a apparently normal feeding case with unexplained respiratory distress. So we need to make sure that the swallowing is not a problem, especially you can see that the growth in the first, after going home for the first 2 months is not good. Next, monitoring. You notice that there was persistent nocturnal desaturation confirmed by overnight oximetry. Why is that so? Most likely it's obstructive sleep apnea syndrome or hypoventilation syndrome. Next. So you saw this chart before, so you can see 3 clusters of desaturation with the SpO2 nadir less than 80%, okay, for more than 3 times. Okay, so this is a McGill grade 3. Suggested a moderate OS obstructive sleep apnea. Next. So this McGill grade 3 with SpO2 less than 80%. Okay. Suggestive of moderate obstructive sleep apnea syndrome. So please, you need to get the data and we need to interpret it with the appropriate reference. Next. In fact, in Hong Kong, we did a study that shown that adding the nadir increases sensitivity. Next. You can see that those on the left-hand side, the apnea hypopnea index less than 1. The nadir, also SpO2 nadir, is significantly higher than the SpO2 and the HI more than 1. So we use the the lowest point oxygen, SpO2, as one of the marker will increase the sensitivity of your overnight oximetry. Next. So if the nadir of the overnight oximetry is less than 90%, the chance of the child having obstructive pulmonary syndrome is 87%. Okay? So you can diagnose it that way, even in the absence of level 2 or level 1 polysomnography. If the nadir is higher, equal to 95%, then it's very unlikely for that child to have sleep apnea, OSAS, unless there's clinically very obvious. Next. So it's important that, well, in this trial, to monitor, as you have evidence of more OSS now, you may like to do a sleep endoscopy to identify the sites of obstructions. If you have tonsil adenoid hypertrophy, you may like to remove it. If they're pharyngomalacia and laryngomalacia is very common in preterm, then you may like to give it support during sleep or like CPAP to prevent the saturation, as well as a poor sleep pattern, sleep quality, leading to impact on the development, the intelligence development, and the other higher cortical function. Next. Monitoring and long-term specific treatment is very important. Dr. Anuradha mentioned about inhaled corticosteroid used twice daily, intermittently. It's not uncommon for these preterm babies with or without BPD or PIG have recurrent wheeze due to virus infections. I think the key is to, when the child was wheezing, we test to respond to salbutamol or bronchodilator. If there's significant response to bronchodilator, and if there's evidence of atopy, like increased eosinophil, then you may like to give inhaled steroids for a short period, like a few weeks to a few months, and then depends on response. If the response is good, you can stop it and see whether it's dependent on it. If the response is not good, then you of course stop it. Okay, and of course there's a chance of it being pharyngomalacia or laryngomalacia or tracheobronchomalacia. So in children with recurrent respiratory distress, especially in preterm trial, it's important to do a flexible bronchoscopy to rule out malaysic segment of the pharynx, the larynx, the trachea, and bronchus, which may predispose to use of CPAP to prevent this deterioration. Next. There's a question from the audience: how many days of intermittent beclomethasone? I mean, if I were the attending person, I would probably give a few weeks and then to see a response, especially if the child is also atopic. So that if I want you to start or start is fail. Next. I suggest to use a tidal breathing method. One of these is forced oscillating technique, which is basically an amplifier that creates different frequency to measure the resistance of the airway and the reactance of the airway. Next. So a 5 Hz measure the resistance from the whole airway, while the 20 Hz measure the proximal airway. And R5, resistance at 5 Hz, minus R20, the resistance at the proximal airway, gives you the distal airway resistance. Okay? And then you can see the response to bronchodilator. Next. So you give bronchodilator, you can also see whether there's significant airway hyperresponsive response to bronchodilator to confirm asthma or not in the young children who cannot do spirometry. Next. This method, FOT also measures reactance. There's the 1 over the compliance. So you can see the expansion of the lung. If there's the increased negative pressure required, then maybe there's actually decrease in the lung volume in the compliance. Okay? So I think it's a very important technique to be acquired in different countries. Next. And so in this model, we can measure total resistance, meaning the distal and proximal. And we can also measure the resistance during the inspiration and the expiration. This is very, very helpful to actually diagnose tracheobronchomalacia because the resistance will be increased when they're doing exploration, when come back inspiration. Next. So the benefit of this tidal breathing lung function over spirometry is that there's no forced breathing required. There's quite independent operator and patients. This actually is not completely true. It still requires some cooperation from parents, from the kid. And we can detect obstruction distally and proximally. And it's also a very helpful tool for pediatric pulmonology development in any country to acquire this tool in your lung function laboratory. Next. So someone asked a question about interrupter resistance. We use the literature is not as prominent as the FOT, and my personal experience range is not that good. So of course, it's also a method that can be used, and the machine is much simpler and cheaper. The resistance of the interrupter. Monitoring is also important. As you can see that the Sri Lankan team did the overnight oximetry 6-minute walk as well. You can see a 6-minute walk show a good walk distance of 489 meters, which is absolutely normal. It's a 75th to 90th centile in the UK children. Next. So the normal values. Okay, next. So remember the kid is 6 years old. He can walk about 479 meters, so it's a 75th centile. Okay, and mind you, this nomogram is for UK children. Let's say in China, in Hong Kong, we actually a study done by Professor Albert Lee, who's in the audience, and we know that for someone with 128 centimeter, the 10 centile for Chinese children is 550 meters. Okay, while the 10 centile in the UK is 449 meters. So for Chinese children, somehow walk much longer than the same age population in the UK. So for each country, we need to develop our own norm, like we did in Hong Kong. Next one. So this study done published by Albert more than 10 years ago about the reference for children, healthy children from 7 to 16 years old. Next. Unfortunately, his age does not cover our patient. Ours is 4 years old, and his is 120 centimeters, 7 years old. Okay, next. So monitor of fitness very important. Monitor of the VO2 max or VO2 peak is very important. So a lot of countries do not have the CPAP machine, the cardiopulmonary exercise test machine. Then we can use a field test like 6-minute walk or the 3-minute step test. Okay, but I find a 3-minute step test is less dependent on the child effort because there's a rhythm. Next one. So I urge you to try to learn this simple technique of 3-minute step test. Basically, ask the kid to step up and down a platform, okay, at a fixed pace of 96 beats per minute, and outcome measure heart rate at 1 minute, okay. So the higher, the worse. So next one. So achieving the best outcome for infant with chronic respiratory insufficiency, including quantifying the respiratory status with oximetry and preferably tidal breathing lung function and track it over time. Assessment by flexible endoscope is important for both the upper airway and the lower airway for nocturnal desaturation, for recurrent wheeze, recurrent respiratory stress. Assessment of fitness by the field test like 3-minute step test or 6-minute walk is important. Prognostic value. Timely respiratory and nutrition support is essential. I must congratulate the Sri Lanka team for excellent work for nutrition support to allow excellent growth of the kid that allow the lung to clear up so well. The good outcome can be achieved even the definite diagnosis is not available. It's very obvious in this case. Grand round is important to achieve the above. So I urge all of you to join a grand round, which will be a regular event for Asia. So I hand the mic back to Dr. Chana, the moderator. Thank you.
Thank you very much. So I would like to thank all the 3 panelists analyzing this case with your nice, very excellent presentations, giving some insights into the management of this type of a challenging case in resource limited setting. Dr. Daniel, Professor Mahesh Babu and Professor Manisa Jana. So I would like to thank all of the panelists all of three again for your excellent input for the success of this grand round. So next, I would like to invite Prof. Ashkan Mosley. He's a pediatric interventional pulmonologist and intervention consultant at the Kuwait, and is one of the member of the APPS advisory board to give his final concluding remarks.
Thank you very much, Dr. Shana, for introducing. On behalf of the advisory board of the Asian Pediatric Pulmonology Society, I would like to extend our heartfelt appreciation to the Childhood Respiratory Disease Study Circle, the official respiratory chapter of the Sri Lanka College of the Pediatricians, for kindly hosting this very great session. Our sincere thanks also go to Dr. Shena, Dr. Arwawan, as the chairman of the society, Dr. Daniel, all APPS board members, presenters, and panelists for their valuable contribution. We kindly encourage you all to share this ground round within your professional networks to help us build a more connected and up-to-date pediatrics respiratory community. I am pleased to announce that the next session will be hosted by our Indonesian colleagues next month on June 25. Thank you very much for everybody joined us today, and hopefully to meet you in the next session in June 25 at this Zoom meeting. Thank you very much and have a very, very good day. Bye.